The postmenopausal to assess for cardiovascular risk factor in your patients, and maybe when you look at female sexual dysfunction, you could also go underline and find something that is more related to cardiovascular risk than what happened in the male space, and actually the same in the female one. So maybe you have an instrument also to start to talk about with your patients about sexuality, because if you want to assess in a diabetic patient if there is some cardiovascular risk, you should also assess for her sexual health and her sexual satisfaction, her type of lubrication. Maybe they could bring a lot of information to you. Any comments on that? Yeah?
Cô còn nói đến cách chúng ta triển khai cái đo siêu âm Doppler âm vật, thì tôi bác sĩ Thành đến từ bệnh viện Phụ sản Trung ương thì rất là mong cô có thể chia sẻ một xíu về hướng dẫn cách chúng ta đo siêu âm Doppler âm vật.
Thank you very much. So actually, it's a very easy tool to learn and also to understand. You have to see perfectly how you have to perform, because otherwise, I think that if you are able to do the penile space, is easier. It's even easier than the male one, because I made both gender, and I feel that this one is easier because clitoris there doesn't move, is in a very precise position, and it's very easy to see in a transverse section the two cavernosa artery and then also the dorsal artery. So it's very easy to do. And the Doppler ultrasound is also able to calculate automatically the pulsatility index as a standard parameter, so it's not actually it's not modified by different operators, because this is exactly calculated by the ultrasound. Any curiosity questions?
Câu đến từ Hà Nội. Tôi có một câu hỏi cho giáo viên. Yes, I have one question. Là trong cái bài của giáo viên có nói là với những mà phụ nữ mà tuổi tiền mãn kinh thì tập thể dục rất là quan trọng để mà cải thiện cái vấn đề sinh hoạt tình dục. Thế bây giờ ngoài những cái vấn đề hoạt động thể chất, ngoài những vấn đề tập thể dục thì còn những biện pháp nào mà hiệu quả hơn để áp dụng để cải thiện cái hoạt động tình dục ở phụ nữ mà cái tuổi tiền mãn kinh không?
So all what we is having an anti-aging more than postmenopausal aging. So I mean, the first thing I would comment is that actually we lose a lot of years in women just waiting for the menopause. We are always saying, okay, because in premenopausal you are protected from cardiovascular risk. Is it true? But you lose a lot of years of prevention, and if you put in place a correct lifestyle, so for example exercise, but also a healthy diet. I mean, in Europe we have the Mediterranean diet is perfect, and you also stop smoking, lose weight, having good position, also psychological position. So you have to face the menopausal transition. This is sometimes destroying the psychological part, and you have to face a new area in your life. So maybe you will win the menopause even, because you are facing the transition in a healthier position. So what I would like to stress is never too early to speak about this problem, to discuss about this problem with your patients. even thinking about that they are aging, and the aging starts even before in women than the menopause. So maybe you can have more harms to protect women against menopause if you do all these things together in the future. So having also the sexual affair to discuss something that in a young lady should be something very easy to talk more than postmenopausal maybe. And you have also something to discuss, something to also to engage women in doing something that is for their healthy aging as well. Okay. If there are no other comments, I think that there is, so it's the time of the General Secretary of our International Society for the Study of Homosexual Health. So it's a great pleasure for me to introduce Professor Tami Rowen, who is a brilliant gynecologist of the University of California. So I am very proud to announce her and to give the floor to her. Thank you, Tami.
Dạ alo chị Chen.
Always hard to follow the president.
Dạ em đang ở hội nghị chị. Dạ em lên từ chiều. Dạ, dạ.
And I hope that I can keep you. I love
Ủa
you.
vậy hả? Dạ để em quay lại. Dạ dạ.
I hope that I can keep you engaged. I know it's the end of the day. I am delighted and honored to be here. Your hospitality and the organization, especially the organizing committee, there's no words to describe how much we appreciate it. And mostly, I'm
về có gì lát chị nhắn em rồi em qua thẳng bên đó luôn.
impressed by your desire to learn and your motivation. It's incredibly impressive to me as an educator to see so many people here paying attention, trying to learn a new skill, and especially as many of you are urologists. I happen to know one very well because I'm married to a urologist. And I do think we sometimes forget that women also have urologic systems. So today I want to focus for this lecture on sexual pain. And sexual pain, I think, is something we're all extremely familiar with, and I think it's quite universal. One of the things that is really important, and I really appreciated us talking about the cultural context in which we work, and thinking about, is it different maybe in Vietnam than for me where I work in San Francisco? And I want to say that what I love about my job in San Francisco is that I see people from all walks of life. We have many Vietnamese people in San Francisco, good Vietnamese restaurants, but we have also large populations of people from South Asia, from India, from Pakistan. We have people from South America, we have people from Africa. And I take care of people who bring many cultural aspects to their sexual well-being. And sexual pain is something I think that is universal across all cultures, but the way that we talk about it might be a little bit different. So at the end of this lecture, my goal for you is to be familiar with the kinds of questions that we can ask that help us determine the cause of sexual pain. I want you to know the steps of a thorough physical exam. So most of what I learned in medical school was not helpful for me once I started taking care of people with sexual problems across the board, but especially related to sexual pain. I'm going to talk to you about a couple common conditions, but also a couple uncommon conditions. Because in my mind, for sexual pain, the history is actually almost everything. The exam oftentimes just confirms my suspicion. But there's several conditions that can cause pain, and there are actually treatments that are available, and some of them may be more available in different types of resource settings, but I think some of the treatments I talk about today will actually be accessible to you in your patients. Okay. So I'm going to go through a couple different cases just to see if this is familiar. So the first case is a young patient who comes saying that she's never been able to have intercourse. Now in our country, most people start to try to have intercourse around age 18 or 19, sometimes it's younger. And so for this patient, she never could put anything inside her vagina, including a tampon. It feels sharp and burning. She is now in a relationship, she's married, and she is okay not having sex, but she wants to have a baby. And obviously you need to, for most people naturally, to have a baby, you have to have sex. She denies any history of trauma, so no sexual abuse. And she's told one other doctor before she saw you that she was having this problem, and they told her it was all psychological and that she needed to relax. So just from my experience with this audience, have you seen patients like this? Raise your hand if you've seen a patient who says she's never ever been able to put anything inside, including a tampon, anything. So a handful of people have seen this. Okay. Here's another type of patient that I oftentimes see. So this is a 27-year-old who initially could have sex. Again, depending on the context, some people have sex outside of marriage, some people have sex at young ages within marriage, who has been on birth, who's been taking them for many years and has noticed a progressive worsening of sexual pain. She felt that she had a small vagina, but she could have intercourse. She's had a couple partners, but now she can't tolerate any penetration. She saw a doctor who sent her to a physical therapist. So do you guys have physical therapy for sexual dysfunction or for pelvic pain? Raise your hand if you have physical therapists, people who do procedures within the vagina. I feel like we saw them at the hospital. People have PTs. So this is oftentimes the first line approach. Oh, I'm going to fall off this stool. And this patient also was told that it was all psychological. And this is a theme. Many patients who have sexual pain get told that it's psychological. This is another type of patient I see. This is a postmenopausal patient. She's had a couple children. She's having worsening pain now with intercourse. I know that I have a lot of acronyms, so letters. I'll try to spell them out for you. And she's noticing an increasing in pain over the last 6 months, and it feels like a sharp and pulling sensation. She went through menopause about 12 years ago and started hormone therapy for symptoms, and she had topical estrogen in the vagina as well as systemic estrogen. She had bleeding then, postmenopausal bleeding, and an endometrial biopsy that showed complex atypical hyperplasia. So that is a pre-cancer. And so she had a total vaginal hysterectomy that she underwent a few months prior to the pain occurring. She has a history of hypertension and takes hydrochlorothiazide. She exercises regularly. And she was worried something went wrong with the surgery, and that's why she is seeing you. So I'm giving you these examples of sexual pain. Is this something that you may have seen someone who had surgery and then maybe complained of pain afterwards? I see some people nodding, right? So these are 3 different examples of the type of sexual pain that you may encounter. And what's really important is that there are 3 different diagnoses here. And the goal is to figure out, I think of myself as a sex detective, what's the diagnosis, and then I can start thinking about the treatment. So I always just give a little background on pain. I'm not going to spend too much time with this, but there is a difference between people who have acute pain and then chronic pain, right? So acute pain is they get touched, they have pain. Chronic pain is a kind of constant, it's hours, daily type of pain. Acute pain is usually in response to protecting the body, whereas chronic pain really isn't. And what's interesting is that within the nervous system, the brain is what picks up pain. So there's you might be touched, but the brain says, oh, that's painful or not. And people who have pain have different ways that their brain responds to sensation. And I think this is incredibly important for young women who have chronic pain their whole life. We oftentimes see that they respond to the same stimulus. You touch them with something soft, they'll experience it as sharp. All right, I'm going to skip through this and say that there's a difference in the way the brain works, and we know that because MRI results have shown us that. So people that have provoked vulvodynia, so chronic vulvar pain from touch, The way they respond to touch is very different. So when we're seeing a patient, this is where it becomes really important to feel comfortable asking questions. And this is where I know that it gets difficult in different cultures with how accustomed people are to talking about their personal lives. But I hope that we can create a safe space within a clinic setting to ask some pretty personal questions. And these are the questions I ask. How long has sex hurt? Has it always hurt? Did it hurt to put anything inside? So in our culture, we use tampons oftentimes in the United States. Not everybody does. But if somebody is going to try to use tampons, I always ask, did that hurt? Did it hurt? Does the pain, was it suddenly they woke up one day and it hurt, or was it over time it got worse? Is it only when they're trying to put something inside, or are they having pain at other times? When they're just sitting down, they have pain. And have they ever been able to have sex without pain? Because sometimes if someone can have sex without pain, then I start thinking about a different type of diagnosis. Sometimes it can be just more anxiety, and when they're relaxed, they're not having pain. Did somebody have a history of trauma? Were they sexually abused? What type of medication were they using? And any other types of exposures that could contribute to their pain. So then I really want to know, where is the pain? And I get very detailed, right? Is it just when something's trying to go inside the vagina? Is it deep inside the vagina? Is it pain with deep thrusting? People have different types of sexual activity. Are there positions that are more or less painful? So some positions there's more deep thrusting, or they get further inside, and some are more shallow. Is there pain with clitoral stimulation, so not in the vagina but in the clitoris? Is there pain after having sex? And what does the pain feel like? Is it burning? Is it raw? Is it like a cut? Does it tear? These are all things that can point in the direction of what could be the cause. So it's very detailed, the kinds of questions. And this is worthwhile because if you get these answers out of patients, it actually can solidify the diagnosis sometimes before the exam. But if I'm going to examine anybody, and they should all be examined if they have sexual pain, there's many parts of the exam. So we want to look, and we want to do something called a cotton swab test. I'll talk you through that. We want to do biopsies if something looks wrong with the skin, and that's really looking for things like lichen sclerosis, lichen planus. Those things sometimes present, especially in very young or very old patients, and you don't want to miss that. If you're going to look inside the vagina, use a small speculum. I don't know about you, but the way I was trained, you would use the largest speculum possible to be able to see the cervix, and that's very painful. Right? So you can use a small one, you can even use a pediatric one, so even one for children, if you need to. Examine the pelvic floor muscles. We'll talk about how to do that. We talk about feeling the bladder and the urethra. Some people have pain in the bladder, you want to feel that, and especially under the urethra, and they can have a diverticulum. And then we always, in our pelvic exams, are used to feeling the uterus and the ovaries dead next to them. So the anatomy of the vulva is really important. And when I was in training, we really didn't learn this, right? Most of the pelvic exam we learn is go into the vagina, feel for the uterus, pretend you feel the ovaries, and then we're done with the exam, right? And we forget sometimes that the vulva is actually the source of most of people's pain. So in the vulva, the most important anatomy to know is this border between the squamous epithelium, so the thicker skin on the labia minora, and this endodermal vestibular tissue, this mucosal tissue. And that's what we call heart's line. And so this is the border of the vestibule. All that pink tissue is the vestibule, it's the opening. And the opening has the urethra, so there's the urethra here, there's the Skene's glands, there's the Bartholin's glands are down here, right where the hymen is, all right? And that's the border of the vestibule. And much of sexual pain you're gonna find is localized to that area. So the way that I examine it is with what's called a cotton swab test. So we take one of those small cotton swabs. I usually will touch their thigh, somewhere that doesn't hurt, and say, this is a Q-tip. It feels soft. And so they know that I'm not trying to hurt them. And then I move it closer and closer. And then I start touching them closer to inside the vestibule. And I start